Damos inicio a este primer bloque llamado Controversias en Real World Evidence, en la generación de Real World Evidence. Y la primera charla le corresponde al doctor Fred Lublin. El doctor Fred Lublin es profesor de neurología en la Escuela de Medicina de Mount Sinai Hospital de New York y es director del Centro Corinne Goldsmith Dickinson para esclerosis múltiple en esa misma institución. Muchas gracias, doctor Fred Lublin, por aceptar de participar en nuestro simposio y adelante con su conferencia.
I'm going to discuss some views on real-world evidence. And the fact that I put the word evidence into quotations gives you an idea of my view on it. And so I will discuss some of the benefits, but mostly some of the concerns about using real-world evidence as evidence. To start with, one has to think about definitions, and I'm going to come back to this several times during this presentation. But to quote Socrates, the beginning of wisdom is the definition of terms. And when one starts to look at analyzing data, studies, clinical trials, you'll see that the definitions used can have a profound effect on the outcomes. The definition of relapse, for example, can be quite different among studies. Relapse-associated worsening, things like PIRA, progression independent of relapse activity. Well, one has to see how independent it actually is. Which activity are you talking about? And true PIRA actually is secondary progressive MS. Some have talked about silent progression, which doesn't make much sense to me. That's more like blind progression. You just didn't see it. And then even the concept of progression, does it behave as a wave, something continuous, or as a particle that is small changes over time that are hard to discern individually? But we'll talk about definitions more. Also, in dealing with real-world evidence, there are special problems related to multiple sclerosis. One is the variability of the illness. So of this serious neurologic conditions, MS is the most variable, from very mild to very severe, everything in between, and very unpredictable. And our ability to prognosticate is rather poor. We also have the well-known placebo effect, and I'll show you some examples of that. And also the confound of changing diagnostic criteria over the last 20 years. So even thinking about the outcome measures that we look at in studies in MS, we have relapse rate, which has some variability to it, measures of disability and progression, MRI activity of various types, quality of life measures, which have not been as informative as we would like in clinical trials, and then other potential metrics. But relapse definitions can play a role. For example, how many days from the relapse till you do the examination? Do you require a change in the EDSS? Disability definitions. Confirmed is the one that's most commonly used, but sustained is more important because sustained means that you never improve from that. And I don't have time to show you all the data, but I can tell you that confirmed disability about 50% of the time is not sustained, making it a less useful determination of long-term impairment. And then by how many months is it confirmed or sustained, and what is the sensitivity of changes in EDSS, for example. And then ultimately you have to decide how much does that really matter. Here's an example of the placebo effect in multiple sclerosis. So this is from the interferon beta 1b study. And if you look at the yellow bars, the placebo group had a reduction in annualized relapse rate every year after the start of the study. The treatment group had a greater reduction and thus led to a statistically significant improvement at 2 years. But if you had done this as an open label study with just placebo, you would have thought you were getting a benefit. And here's another example of a reduction in gadolinium enhancing lesions in an open label trial of simvastatin, showing you a reduction from baseline to treatment. But we did another study where we looked also at gadolinium enhancing lesions. And if you look from months -2 to 0, The only thing that changed during that time period was patients signed a consent form. Therapy wasn't changed, showing you that you can see an effect that you might think was biological, that really was not biological at all. And here's another example from the Sylvia Lowry Center database of placebo behavior. And what you can see here is that placebo in different clinical trials behaved vastly different, sometimes showing considerable worsening, and this is in time to first relapse, and other times showing very little change over time. And your clinical trial, a randomized clinical trial, was dependent on what happens in that placebo group, because the placebo group doesn't worsen. You can't show that your treatment is effective. And yet another example of the differences in placebo over time. And so if you look at the placebo groups, for example, sorry, I backed up one. The group here, Clarity placebo, and there's another one in here too. That placebo group there is more effective than earlier studies of effective therapies, which just highlights the point that there's so much variability in MS that you can't compare across clinical trials and never should, but it also means that observational studies have the same challenges. And here's another example of the European interferon 1B secondary progressive trial. This was done in Europe, and it was stopped early for overwhelming evidence of efficacy. But the same study, practically the same study, was carried out in North America, and this was stopped early for a statistical futility. Identical designs, and there should have been identical treatment groups, but it turned out the groups that were entered were not very similar, and that led to the differences in the outcomes. So there is a hierarchy, the strength of evidence. So the least strong is anecdotal case reports, followed by series without controls, series with literature controls, series with natural historical controls, observational studies, single randomized clinical trials, and the gold standard is the confirmed randomized clinical trials. And for example, one of the issues that we're trying to sort through in treating patients is how do we start out with initial therapies? And we have this dynamic of whether we should use an escalation approach, starting out with safe and moderately effective, and then if that doesn't work, going on to more highly effective therapies, or starting right away with highly effective therapies that may have more safety concerns than some of the other approaches. And there's a number of observational studies that have suggested one outcome or the other. But here are these two PCORI studies, the Deliver and Treat, which hope to utilize good designs with randomization to answer this question. And this is important because we need to get an answer, and hopefully these will. The last PCORI study, oh, I didn't do that. The last PCORI study down here, the DISCO study, was designed to try and answer the question of whether we can stop therapies in an organized fashion. So how we choose therapies. We have natural history versus unnatural history. Natural history is what you would see in observational studies of sorts. Unnatural history is the randomized clinical trials because they're focused, they're designed to be homogeneous, they're designed to answer the question, but they have some limitations. Observational studies, take the group as you have it, is broader, and I'll go through some of the other benefits there. So how do you compare them? You make statistical inferences, but who knows where the biases are? And one can never control for all of the biases because they may be unknown, and bias will beat statistics. So here are some real-world considerations in initiating treatment that will impact how one analyzes an observational trial. There's the frequency and severity of relapses, the duration since onset of disease, lesion burden, lesion location, residual deficits, formulary restrictions, out-of-pocket costs, safety preference, risk tolerance, monitoring requirements, route of administration, age, planning for future pregnancies, comorbidities, impairment impacting monitoring or adherence, ethnicity, and also there's physician factors. Some physicians just prefer to use certain therapies over others, and that would change how their observational data is looked at. And one can look at clinical trial extension studies, which are kind of observational, and they have the same difficulties, no placebo control. It's difficult to maintain patients in long-term studies. There's not very good quality. If you do it retrospectively, you can have incomplete monitoring. You have the issue of dropouts. You have the issues of drug switching and difficulties of confirming EDSS progression. So what are some of the values? So by definition, real-world data collections are much more extensive. They're long-term, and they're more population representative than clinical trials. And you have the issue of effectiveness versus efficacy. So a randomized clinical trial is going to determine efficacy, how well a particular drug worked in that study. But effectiveness is how well that drug performs in reality, in practice. And you don't get that from a clinical trial, but you can get evidence for effectiveness in real-world data. It also allows you to build models for predicting treatment responses. And this is very important and a very important use of real-world data. They contribute to the study of effects of drugs in MS patients with comorbidities. Very often comorbidities are excluded from the clinical trial, and therefore you don't have an idea how those populations perform. Similarly, in specific populations such as pediatrics or pregnancy, these may not be analyzed in clinical trials. And it may provide accurate information on the safety profile of a drug, revealing rare events. So this is also very important, that real-world data is especially useful in looking at safety, and it may allow some comparison across drugs. So current approaches are large observational studies. These are getting better. There are some very large sample sizes, such as MS base, but you do have quality challenges in the collection of the information. There are standardization difficulties across multiple centers, but they do provide group data. There is the challenge of validation other than the difficulties with confirmation bias. So this comes from Dan Otanea's paper. Observational data not only complement the results of clinical trials, but also enable direct comparisons of treatment effectiveness in different clinical scenarios, conditional on sufficient control of confounding, in particular indication bias. And the control of confounding is, in fact, the biggest challenge to these studies. So other problems with observational studies, there's a lack of randomization. You have selection bias. If done in a single center, you have systemic bias. With multi-center studies, you have less control over the variables. You have difficulty of controlling for baseline differences. People love to use propensity scoring. I will show you a somewhat different view of that because there are hazards with it. And perhaps most importantly, there are unknown, unrecognized confounds and biases that can have a vast effect on the outcome of observational studies. And there's no standardization of various definitions, including inadequate treatment response. So there is a push these days for looking at more pragmatic trials because they more broadly represent the population that one wants to look at. Explanatory trials are the randomized clinical trials. Their value is that they have high internal validity, they're smaller sample size, they have sophisticated designs, they involve a controlled environment, and they're the kind of things we look at in phase 3 and sometimes phase 2 trials. The pragmatic trials, the observational types, are high external validity, large sample size. They're mostly simple designs because they can't be too complex, and they involve a diverse settings and are mostly phase 4. Pragmatic trials are conducted in real-life settings encompassing the full spectrum of the population to which an intervention will be applied. The pragmatic design is an emerging concept and it's here to stay. The scientific community, practitioners of policymakers, as well as healthcare recipients should be sensitized to the pragmatic concept and should even demand more evidence applicable to real-life settings. However, this process should not be done at the expense of exploratory trials. We need both to answer the complicated questions lying ahead of us. And this is very important to understand what each of these is telling us. Here's a good example. This was a study on workplace wellness programs, and Dr. Aaron Carroll wrote this up in the New York Times a few years ago about when people were complaining about randomized clinical trials. And what happened was there was a workplace study which involved both an observational study and a nested randomization group. And when they looked at the intervention group, and this was on workplace health initiatives, it appeared that people using this program did better. And on that, they based it was the program was a success. But when the intervention group was compared to a control group as a randomized controlled trial, the differences disappeared. There was nothing. So it was highlighting within the same study how the observational group gave a different answer than the randomized controlled group. Now, in observational studies and in randomized clinical trials, you try to adjust and control for variables that you can measure. In this study, they did that. They controlled for sex, age, race, salary, status as faculty or staff, and it didn't make any difference at all. They even went to looking at machine learning to control for even more variables, including past health, smoking, drinking status, and the differences were still unchanged. And so even trying to control for all the variables you understand doesn't mean that you're controlling for all the possible variables. So observational research can be the best way to study population level effects. In those cases, many researchers are exploring new techniques like the use of regression discontinuity, a technique to create quasi-randomized groups for analysis. Still, randomized controlled trials remain much more reliable and useful than other types of studies. In our eagerness to point out their flaws, we shouldn't overlook their benefits. So some of the things we don't know. How best to define inadequate response and subsequent switch strategies. How to determine responders. We need more head-to-head comparative studies to set the standards for more pragmatic designs. Are real-world pragmatic trials sufficient evidence? Well, probably not, because it's unclear how to validate them and what standard to use. How to remove all the bias and confounds, especially the ones that are not recognized. There are important lessons to be learned from observational studies, including, safety. And so this Swedish study demonstrated serious infection risks were greater in rituximab-treated patients and greater use of antivirals in other therapies. So safety is an important benefit to be obtained from observational studies. Now let's come back to definitions, because this affects how one views data. So this is data from the CombiRx study, where we used 3 different definitions of relapse. And from the most stringent, which was the PDE, the protocol-defined exacerbation, to a second one, protocol-defined, non-protocol-defined. So it was still stringent, but less stringent to anything the investigator called a relapse. And by altering these definitions, you double and triple the annualized relapse rate from the most stringent definition. And so this is not taken into consideration when one looks at observational studies. And it's important because look here what it does to the absolute risk reduction and the relative risk reductions. When you use a stringent, the protocol-defined relapse versus somewhat less stringent definition, you change those risks. And that leads to a change in things like the number needed to treat. So with the most stringent definition of a relapse, the number needed to treat was 17.5. But using a less stringent definition, but still a reasonable definition, that number needed to treat goes down to 12. Also, here's another example of comparing randomized clinical trials to observational data. This is work that came out in Brain. It's coming out in Brain in September. It's already available online using a database of about 27,000 patients that were involved in both randomized clinical trials and observational trials. And it comes from an analysis from the Oxford Big Data Group. And what you see here is on the phase 3 trials, you can look at something called PIRA, right? Progression independent of relapse activity, which are the green bars. And this is sustained PIRA. In the randomized clinical trials, 34% of those that had sustained change in EDSS did it by PIRA. But when you look at the whole data set, which includes all of the observational studies, you now see 47.3% of individuals are progressing independent of relapse activity, which means that they're getting a different result. But it also means that they're probably not picking up the relapses because it wasn't, the observational study just wasn't designed, because it's a retrospective design, to pick up all of the data. So these kind of differences are important to take into consideration. And here is a good example because we are using the same analysis, both in the randomized clinical trial and in the full data set. Here's a stronger view from the Royal Statistical Society that any claim coming from an observational study is most likely to be wrong. Startling but true. Coffee causes pancreatic cancer? Nope. Type A personality causes heart attacks? Nope. Trans fat is killer. Women who eat breakfast cereal give birth to more boys. All these claims came from observational studies. When the studies are carefully examined, the claim links appear to be incorrect. What's going wrong? Some have suggested that the scientific method is failing, that nature itself is playing tricks on us. But it's our way of studying nature that is broken and that urgently needs mending. Some problematic examples: the CAST study of cardiac arrhythmias, the arrhythmic drugs caused more deaths. Women's Health Initiative on hormone replacement therapy missed the mark on that. Vitamin E and selenium are good for preventing prostate cancer. In open label studies, yes. When actually controlled studies, the vitamin E group ended up causing more cancers, or having more cancers, not necessarily causing. Vitamin B6 for inflammation and perimenstrual syndrome, actually too much caused nerve damage and little evidence that it was effective. And so I'll leave you with some thoughts on moving forward. One is the plural of anecdote is not data, it's anecdotes. The aphorism of Galen, all who drink of this remedy recover, except for those whom it does not help, who all die. Therefore, it is obvious that it fails only in incurable cases, and that when evidence contradicts beliefs, beliefs usually prevail. So conclusions: big data is not the same as good data. Inaccurate data is not better than no data. There is a computer big data rule: garbage in, garbage out. Association does not equal causality. Full control of bias and confounds is unlikely to occur. Randomized clinical trials are still the gold standard. Real-world evidence are best employed to confirm and expand on the randomized clinical trial results, or to generate hypotheses for clinical trial results. They're important to do. We just need to know their strengths and their limitations. And with that, this is my group in New York City. I thank you for your attention.
Thank you very much, Dr. Lublin. You was very, very clear, and I suppose that the audience must take into account all your concepts after or putting together this with the previous conference of Dr. Kalinsik. As you remarked, the control of bias is it's the big point. And do you think that probably there are now developing new technologies for controlling the bias in a better manner than with the instruments that we have nowadays?
I suspect they get better and better. The problem is there's no way to be certain, and it's difficult to you know if you take the what's the word I want, the range from observational studies to randomized clinical trials, what you're actually doing is cutting down on variables as best one can until you get to randomization. But all along the way there, this hierarchy, you still have things you can't control. And even in randomized clinical trials, there's things that come up that turned out you can't control. But you know, you use as homogeneous group as possible. You have a standardized protocol. It's prospective. Everyone understands, you know, the assessments to be done. But as you move along that spectrum away from that, you put in more confounds, and some of them can never be completely controlled. So the bigger your data group, the more centers you have involved, the less control you have over how the assessments are done in individual centers. And you could try your best to standardize it, but you're going and looking at data that was collected often retrospectively, and you can't correct for what wasn't done. And you don't have as much control over dropouts. So the word is there's a spectrum there, and one has to try and apply it as best one can. Mostly really good for safety, good for group analyses and expanding on populations that weren't covered in the randomized clinical trials, and for generating hypotheses for moving along. It's a little like the post hoc analyses that you do from a randomized clinical trial. That's not evidence, that's hypothesis generating.
Yes. And I have a question for you, Dr. Lublin. From your personal point of view, which is the best statistical method to solve the majority, or probably the majority of problems we can find for generation of real-world evidence? Propensity score, for example, another statistical tool, nothing?
I don't know. I'm not enough of a statistician to answer that question. So I would throw that question to Professor Sormani and ask her. And she's tried. I know she's thought about these things. And so she would be someone who could give you a better view on that than I can. I know there's problems with propensity testing, and people sort of love it, but some people love to hate it.
Okay. Okay. And so what can we do for improve real world generation? There's something that can we do?
I guess the most important thing to do is to understand its limitations and not overinterpret it.
Yes, yes, I absolutely agree with you.
Okay, Dr. Lublin, we are on time, so we have a lot of questions, but we can do them. So thanks a lot for your very, very clear, interesting, and amazing lecture, and see you on the next time, and thanks again.
All right. Good luck with your program.
Thank you very much.
Take care.
Have a good day.